everybody, welcome back. My name is Ashley Cooley. I am the owner of Birth Baby Sleep and host of the Bringing Up Baby podcast. And welcome to episode 100. We have been doing this podcast since early 2021. I call the podcast my COVID baby because it was during the early phases of COVID in 2020 where I just had this huge desire and drive and passion to get out more information to those who are pregnant, who are preparing for childbirth, who are postpartum, who have babies, who have young kids. This time in our lives where we need so much support and information and good quality evidence-based information, but given in a practical way so that you can apply it to your baby, to yourself, to your family. And we're at episode 100 now. And so that's pretty cool. We're still going strong. And today's episode, speaking of evidence-based practical information, today's episode, I'm chatting with our good friend Kelsey Marr again. And Kelsey, being a local doula here in Halifax and a birth researcher, she has a PhD. She joined me for today's episode to chat about, drumroll please, epidurals. Epidurals are a big topic when we're pregnant, when we're thinking about preparing for childbirth. As many of you know, I do teach prenatal classes here locally in Halifax. We also have some virtual classes, but I'm talking all the time about ways to support yourself and your partner during childbirth and labor prep. And a lot of times, epidurals are part of that. Not always, but this is just yet another avenue, another way, whether you join me in my prenatal classes or not, to get some good quality, evidence-based, what does the research tell us about epidurals, about if it's or when it's too late to get an epidural, how it's administered, what are the risks and benefits, what might determine epidural usage, what is this quote unquote walking epidural, and can I get one? What does that mean? We even answer the question, are you more likely to have a C-section if you get an epidural? These are all very, very common questions, topics, concerns around epidurals that I hear, that Kelsey hears, that a lot of us in the birthing community hear about. And so what better way to get out some information than through this podcast? Episode 100, very special milestone for us. So thank you for listening. Keep on listening, keep sharing, because we all need more quality information with non-judgmental support and access to resources. So I hope that's how you think of the Bringing Up Baby podcast. But without further ado, here's today's episode. Here's my conversation with Kelsey around epidurals. When we talk about this in our labor and delivery class, it gets a lot of airtime because people naturally have a lot of questions. Normally, or I shouldn't say normally, but most commonly when people are showing up at my prenatal classes, it is for their first baby. Not always, but a lot of the time. So very new scenario that they're going into with labor. And well, correct me if I'm wrong, because you have the research, but there is a pretty high rate of epidurals, especially for first babies here at the IWK where we are. But I know at a lot of big or teaching hospitals that rates are usually on the higher side. But yet, even with those rates being higher, and you can maybe share with us what those are, people are afraid. The number one question is, will it ever be too late? Like, they're scared that they're not going to get one because they maybe have a friend or a friend's friend has said, I wanted an epidural, and the nurse said no. Yeah. And that's definitely what people are afraid of, and understandably, because if you want extra support for pain relief, you wanted it yesterday by the time you asked for it. And people being scared of not getting it in time, I think, can sometimes cause them to get it earlier when they maybe don't need it, or as a just in case. But then, you know, what we're going to talk about too is like the research behind what that all entails. So why don't we start with the question of, is it ever too late to get an epidural? And when is that, and what does that look like?
So, like, the short answer is no. In terms of, no, it's never too late to get an epidural. In terms of how your body is going to physiologically react to that pain medication. So, what we're using here at the IWK, and it is different at different institutions and in different countries, but the actual medication used in the epidural is fentanyl here, being administered, and sometimes that freaks people out because of the current fentanyl crisis.
Yeah. It's fentanyl and a numbing medication as well, right?
Exactly. Yeah. But it's fentanyl being used in a very safe way. And we see good outcomes for both the birthing person and baby using that medication in an epidural. The issue with it being too late has more to do with like practicality than it does with physiology. So here at the IWK, we need to have an anesthetist or an anesthesiologist able to place that epidural, right? And so if they have to go in for a C-section, because they would also be the person in the room, making sure that if somebody's getting a C-section, they're nicely comfortable. They might not be available right away for you to get an epidural. So sometimes what I'll see one of the labor and delivery nurses do is I'll ask my client about pain management, and then they'll say, right now the anesthesiologist is available, we can bring them in and have them place it. Whereas the risk is if the if say you're like, no, I don't want it right now, the anesthesiologist gets called into a C-section, then you have to wait for them to come out. And those procedures generally take about an hour, but can take longer depending what's happening in the C-section. And your labor is going to progress during that time, right? The other thing is for you to have the epidural placed, and we can talk more about what that process looks like if that's of interest too, you end up sitting up. And so if baby's head is really low in the vaginal canal, it's really uncomfortable to sit on top of their head. And so it's not that it's too late to place the epidural, but if baby's head is really, really low, it may be better to see, like, usually at that point you're dilated. If baby's head is that low, you're already in a pushing phase. You're more likely to get baby out at that phase than you are to get like a benefit from having that epidural placed. So short answer, no, but you might run into practicalities and actually having it done.
Absolutely. Thanks for breaking that down. I can attest to that last part that you said, because I did have, of the 3 births that I've had, I had epidurals for the first 2. I had the procedure done when I was roughly around the same dilation, like 7 to 8 centimeters or so. But with my second, naturally, she was coming a little bit quicker. But I asked for the epidural, and I was 6 centimeters, and I was hanging out at 6 centimeters because I wasn't moving, or etc., whatever the reason was. And so I asked for the epidural. And it was an hour, so must have been in the OR or something, but it was an hour from when I asked for it to when it was received. But in that time, I went from 6 centimeters to 10 centimeters and did not realize. I was just laying down, taking it until that anesthesiologist came into the room. I sat up in that position, and I tell people in our prenatal classes all the time when they ask, and we're talking about this specifically, that I personally found sitting still in that position in transition at that very late stage, that was harder than almost anything in any of the labors combined. Like it wasn't that long. It was a couple minutes, but it felt like a couple of hours. And it was so late in the game that as soon as the needle is out, taping that tube to my back, the nurse is looking at me like, do you want to push? And I'm like, I think so.
Yeah.
And so I just had my baby before the anesthesiologist got out of the room.
Well,
like,
the other thing is, like, when we place that epidural, because
Sure.
I have nothing to do with it. But when that epidural is placed, the effect isn't immediate, right? Like, it takes about 20 minutes for the medication to really kick in, and for, like, with that medication, you're still going to feel pressure. Mm-hmm. You're still going to feel the pressure of baby's head descending. You're still going to feel like the stretching as baby's head comes out. We can't get rid of that. It will get rid of the pain of the contractions. But if it's going to take if you're 10 centimeters dilated, you're holding that position to, like, and you have to sit quite still for it to be placed. And then, like, there's the medication.
And you're having a contracting. You're contracting that whole time because you're late in the stage, and it's really hard.
And so, I mean, it can't be too late. But, I mean, if an epidural, I say to my clients, if an epidural is part of your pain management plan, you do just want to be aware of, it's not going to be immediate. Like, you might have to wait for that epidural to show up. Mm-hmm. You might have to wait for the epidural to kick in. And we never know how long labor is going to be. You could sit at 6 centimeters for 3 or 4 hours, and then suddenly you have a baby. Yeah,
exactly. I think that's really valuable for people to hear. It still doesn't leave, to me, when we finish these conversations in class, it still just leaves this hanging question mark of, like, oh, okay, I got some more info, but, like, I guess we're not going to know until the time and how things are going. So, and it can be hard to know. I remember even trying to make that decision with my first labor. Like, I know the epidural, I hear it's going to be helpful with managing the pain of these contractions, but, like, do I want a needle where it's going, and what's that all? So maybe can we talk about the process a little bit?
Sure.
And what that looks like?
So maybe I'll kind of just give from, like, I can only speak from experience as to what it looks like at the IWK. So if somebody's delivering at a different hospital, it might look slightly different. But what usually happens is you let your nurse know that you're looking for an epidural, and they'll inform the anesthesiology team. And the anesthesiology team will come into the birth room with a silver cart that has all their instruments in it, and they get the birthing person sitting up on the birth bed. You scoot your butt to as far back as you can, and they'll give you a warning. They'll be like, you're gonna feel like you're falling off, but you're not gonna fall off. We're here. There's 2 people behind you supporting you.
They need you in a really specific position.
Very specific position. So your butt's all the way back. Your legs are in front of you, kind of cross-legged. And usually your birthing nurse is standing in front of you. And I should say, like, your partner, your doula, are usually able to stay in the room with you during this process. So once you're scooted back and your legs are placed and anesthesia is ready, they usually give you a pillow to hold and get you to push out the epidural space in your back, which is, like, very much forming your body into a C around that pillow to try to push out that space that they're going into as much as possible.
So you're rounding the back, and I've heard someone once recently share with me that the anesthesiologist at the hospital here where she was being cared for was telling her to round her back, and he was yelling, "Cat like Halloween, cat like Halloween."
Exactly. Like if you do, like, cat-cow position. Yeah. Right? A lot like that.
But you have to do it more than you think you do. Like,
it's a lot.
They really want you to
it's
out.
hard because you're contracting, you're dilated,
you have a baby.
You have a great big belly in front of you, you're trying to take this shape. They're going to clean your back and set up, like, a sterile space on your back. And then the actual, like, placing of the epidural, they take a very, very tiny needle attached to a very tiny catheter. Very, very small. That needle goes into your back, into your spine, in that epidural space.
And they're numbing that first.
They're numbing that first. So you're not going to, you might feel a little pinch.
Yeah.
You're not really going to feel this. That needle goes in, the catheter gets placed, and the needle comes out. Mm-hmm. So once your epidural is placed, nothing sharp is staying in your back. Mm-hmm. That they get that catheter in, they tape it up so that the catheter can't move. Mm-hmm. And then your kind of like uncomfortable position sitting is done. Mm-hmm. Because at that point, they're going to attach that catheter to a pump that delivers the medication. Mm. So with, like, I get questions all the time of like, well, if the needle's going into their back, can I lie down? Can I move? Stuff like that. Mm. The needle comes out, the catheter is taped. You can absolutely lie down, turn over, do whatever you need to do with that catheter placed.
I do love getting to share with people because sometimes they worry that like, oh, well, they tape it to my back, but like, can I lie back? Can I still move? Like, oh yeah, you should be more asking like, how many weeks is it going to take me to peel that tape off my back in the shower?
It's a lot.
Because it's there. It's very, very there. Looking for the best for your baby? Atlantic Canada's Baby Store is here for you. Nurtured, which is right here in Halifax, Nova Scotia, has the best products for baby. The staff are so incredibly helpful, and they have the most top-rated car seats and strollers you won't find anywhere else. So whether you need expert advice or the perfect baby gear, Nurtured's got you covered. Nurtured, supporting your parenting journey every step of the way. You just mentioned something that came to mind for me, and again, it's very, very common to get asked this question. Walking epidurals.
Yeah.
What's a walking epidural? Air quotes. How can I get one of those? I want to still be able to move with that. Yeah, can you talk us through that?
A walking epidural, and I'm also using air quotes.
Always air quotes.
Always air quotes. In different hospitals with different anesthesiologists, epidurals are practiced a little bit differently. The medication might be different. The amount of medication given to a patient might be different.
Per hospital. Okay.
So what we're seeing at the IWK is that we're using fentanyl. I don't know what the dose calculation is because I'm not an anesthesiologist, but they're figuring that out.
Yeah.
And the idea behind a walking epidural is that, there's a story about epidurals that as soon as you get one, you're stuck in the bed. You can't move. Yeah. Your body's heavy.
Yeah.
A walking epidural is supposedly supposed to let you move around more, theoretically walk with it.
Yeah.
What I see here at the IWK is it has much more to do with how an individual birthing person's body processes the medication. Yeah. So some of my clients, they get their epidural and their legs do feel heavy. Mm-hmm. We can absolutely do different positions in bed, but they might need some help moving their legs because their legs are numb. Mm. Others are able to stand up, get out of bed. The nurse will have you do like a little squat to make sure you can feel your legs first, and they can walk to the bathroom and pee and come back to bed with their epidural placed. Mm-hmm. So it's not, at least here, not that we have to request that. It is a lot more about your personal physiology and how you're going to react to the medication. And unfortunately, you're not going to know that until you have the
So
medication.
Everyone gets the same dose.
Well, it would be a dose calculation based on your weight, your personal information, all of that sort of stuff.
So there's not actually hey, can I get the lower dose? Can I get the X? They're probably giving you the lowest dose possible that will take effect.
I would expect so.
Yeah.
Yeah.
So it is interesting how some people are able to move around more where others find it more of a struggle. But that's kind of been my understanding too. So thanks for clarifying that.
Of course.
It really depends on... And would it depend too on how much you were given? Or does that have more an effect on how long it might take for it to go away, I guess?
So it's not that you're being given the dose one time, right? The medication one time. Mm-hmm. So I mentioned that catheter is attached to a pump. Mm-hmm. So what it actually looks like is you'll have kind of an IV stand. It's got a pump on it, and that pump is in a lock box with the medication. So somebody has to have the keys to get in there to fuss with the medication, fuss with the dosage. And that pump will deliver a dose through the catheter every 40 minutes. So that you're getting
whether you're pressing that button or not?
Whether you're pressing that button or not, you are getting the
every 40
base
minutes.
level
of
that your medication is every 40 minutes. There is so as Ashley just kind of mentioned, there is a button. It's like attached to that pump. Mm-hmm. And that button allows the birthing person, the person with the epidural, to give themselves an extra dose if they still feel that they are getting like a sensation or pain or discomfort. Okay. That button does have a lockout on it, though. So I always stress to my clients, before they go in for an epidural, there's no risk of overdosing. Mm-hmm. You're not going to press the button too many times. Like, sometimes it just makes you feel better to press the button.
Oh my gosh.
Right?
I
to
literally
feel like you have that control.
When the doctor first handed it over to me, the anesthesiologist, and I was like, oh my God, you're giving me control over this? Like, can I just hold it down? Like, what will happen?
Yeah. So there's no risk of that. But the base level is, they're getting a dose based on their body weight and all of those different factors that I'm sure anesthesiologists think about every 40 minutes. And then you can top that up if you need to top that up.
Okay, I didn't realize that it was extra, that you would, because it's on the pump, every 40 minutes it's going to give you that med.
Yeah.
Unless you give yourself extra.
And you can hear the pumps. So if you're not the birthing person and you have the ability to focus on other things in the room, you can hear the pump cycle. So you know when it's delivering the dose.
Okay.
Yeah.
All right. Very interesting. Back to what I was mentioned first to start the conversation, and just forgot to ask it. Do we have stats on, am I correct in saying that it's about 85 to 90%?
That's my understanding at the IWK.
At the IWK for people having their first baby.
Yes.
Specifically. And that it drops to about less than half if it is your second or third or...
Those are the most recent numbers that I've heard too.
So in your experience as a birth researcher and doula, why do you think that those rates drop so drastically when it is a second, third? I always assume like part of it must have to do with the fact that subsequent babies can come a little faster oftentimes. I attribute my decision to labor without an epidural with my third pregnancy to better education, better mindset, and having had experience in labor before, having known what contractions can feel like, especially like later into the labor, and just kind of deciding, hey, I know that's coming, but I have these tools to set me up for it. So personally, I feel like that's what helped me. But what's your take?
I think you're kind of hitting the nail on the head. So, I work with a lot of first-time parents, and most often what I hear from my first-time clients is, I'm open to the idea of having an epidural, but I'd like to try to birth unmedicated. And secretly in my head, without judgment, what I say to myself is, we're getting an epidural in this case.
And I think that's probably what the nurses are assuming too, because, hey, if this is your first baby and these are the rates here, more often than not, more likely than not, they're going to want one.
And part of what my mindset around that is, if I have a client who says, I want to have an unmedicated birth, they do a lot of prep to have an unmedicated birth. They are of a mindset that, if that is something that is very important to them, usually they do a lot of self-education on unmedicated birth. They do a lot of preparation. And we can talk more about what that prep looks like, but they're very, very committed to it. Whereas if somebody says, I'm open to the possibility of epidurals, this is not to say that this is the case for everybody, but I see that people then walk in the door with less mindset preparation around what their labor could feel like. And so I think like you said, there's the element of how you educate yourself, who you reach out to for education before having your first baby. There's also the element of that mindset piece, because what we don't necessarily know before having our first baby is labor is a marathon. Labor is painful. And it is one of the few times in our lives that pain equates good. Usually we see pain as a bad thing.
Right.
And in this way, in the case of birthing your baby, for the vast majority of people, the pain they experience is what their body is supposed to be doing to birth that baby. And so there is a mindset shift that has to happen for us to work through that process unmedicated. I do think also, like, in terms of pain management options, we know that the epidural is very effective. We know that the risks to mom and baby are relatively low. People, I think, feel safer taking an epidural versus taking an injectable opioid based on the, like, one, on the perception of injectable opioids, two, on what we do see in terms of some of the risks and benefits. And then I also think, like you say, experience. Like, if you know, so one, from two different standpoints. One, if you know what labor feels like, then you know, maybe you're like, oh, well, this now feels like transition. So I know this. I don't necessarily need to get the epidural now because I'm tolerating things well and I know my baby's going to be here relatively soon. The other standpoint is, if you have had a negative birth experience or birth trauma, or had and somehow that's connected to your experience of an epidural, sometimes we see people attempt an unmedicated birth after having an epidural because they did not like that previous experience for whatever reason.
I always tell people how it's there for you if you need it. Like, and because I do agree that a lot of people coming to my prenatal classes are of some have, there's two extremes of, one is, I really want to try to do this unmedicated, but good to know what's available just in case. Another extreme is, how soon can I get to the hospital so that I can get the epidural or whatever else is available. And then so many of us live in that middle ground of, like, okay, I know what my options are. I haven't been here before, but I'm just going to go and see how it goes. And then, see how it goes. I found that, and, you know, I had my first child over 12 years ago now, which is so wild to say out loud, but, like, it feels forever ago. But I just remember, obviously, you know, when you're pregnant, usually you're trying to eat well for you, like, you're trying to, like, and you know, anything you're ingesting is going to the baby and stuff like that. So oh my god, I'm tired today. I was gonna say, trying not to take drugs while you're pregnant, like, please don't. But, like, you're avoiding those things in pregnancy, and then you get to labor and it's like, oh, am I gonna do this? Is this gonna quote unquote drug my baby? This isn't how we're quote unquote supposed to do it. But I tell people, like, gosh, sometimes the epidural is what helps you relax enough so that you can birth your baby how you want to. Like, that tension that we can't necessarily get rid of, it can be helpful to that. But then this question comes up, and I'd love to hear your thoughts on it, because I know I have my own. Are you more likely to have a C-section if you get an epidural?
So as we were getting ready to talk about this, I went back to the research just to double check it, because this is something I hear all the time too. And there is one of the documented risks for a birthing person with an epidural is that we do see higher rates of C-sections because of fetal distress. Now, I'm going to caveat that and say a Cochrane review, which is a huge meta-analysis, very, very high quality research, found that epidurals do not increase the overall risk of C-section. So there's a difference there. There's the overall risk of C-section, And then there's kind of within that big category, a nuanced category of, yes, there is an increased risk for a C-section due to fetal distress.
So would that mean then there's an increased risk of fetal distress with an epidural?
So there's at least an increased risk of perceived fetal distress.
Ooh.
So one of the things that happens when you have an epidural, let me back up a step. So if you don't have an epidural and you're laboring in the hospital, they will monitor your baby from time to time. So
while you have a contraction.
While you have a contraction.
Yeah.
So what they'll do is, every 30 minutes or so, they take your blood pressure and then they take like the sonogram, the Doppler that you probably see during your prenatals. They put it on your belly. They listen to baby's heart rate. And they say, okay, baby's doing good. And you move on. If you get an epidural, most often you are put on continuous fetal monitoring. Again, this is policy here.
Yeah.
It might be different in different hospitals. And what that means is instead of having that Doppler check on your belly to check the baby's heart rate every 30 minutes or so, they'll strap a monitor to your belly, and they have these stretchy blue and pink straps. And it takes a continuous reading of baby's heart rate. It also takes a continuous reading of your contractions. And because we have that continuous reading, we see every fluctuation in baby's heart rate, right? And it is totally normal for baby's heart rate to fluctuate somewhat during labor because like babies, we're contracting, baby's getting squished, baby's moving, all of that. But what the research does show us is because we have this overabundance of information where we see all of these fluctuations. This is, I'm not saying every nurse or every doctor or in every situation over responds or over corrects to those fluctuations, but we do see higher rates of responding to what may or may not be a normal fluctuation with a higher level of caution.
Yeah.
So what we might perceive as fetal distress rather than what may or may not actually be fetal distress.
Right. Oh, what a good point.
Did you know that laboring in an upright position is associated with faster labor times and a decrease in the rate of interventions? Like I'm talking up to a 25% decrease in C-section deliveries alone. I know for me, I'm constantly talking about and demonstrating different ways to use gravity in your favor during labor in our prenatal classes, and the birth sling is part of that discussion. It safely holds up to 400 pounds, it's easy to clean, and it comes in a few different colors. So if you'd like to get your hands on your own birth sling, use the link in our show notes and use code BIRTHBABYSLEEP at checkout to receive $10 off your order. That's thebirthsling.com with the specific link in our show notes, using BirthBabySleep for $10 off your order.
Yes, risks and benefits of epidurals. I approach this as a childbirth educator, knowing that like you have the ability to really hone in on your clients and like this one-on-one, like what do you want? What is your ideal? Or let's talk about this, let's answer that. Whereas in a class, like I was just saying earlier, I could have people on both ends of the spectrum.
Absolutely.
And then people in the middle. So we're trying to like give that general information. There certainly are risks and benefits, and we do talk about those. But I think practically people just want to be like, how can I make sure that I'm as comfortable as I want to be or can be and still have these healthy outcomes? And planning and knowledge and what we're going to talk about here now is probably going to be very helpful. But ultimately, I feel like when it all trickles down and boils down and we're in the moment and we're in the hospital, it's what do you need right now to get to your next moment? Like, what do you need if somebody could be planning to, say, have an unmedicated birth, but maybe they've been awake and laboring overnight for a day or two and off and on, and they're exhausted, and the epidural is actually going to give them the opportunity to have a rest so that they can get to that pushing phase or what have you. So there can be so many, we can talk about the pros and cons all the time. So I think it's important to know about them and make informed decisions about that. But ultimately, when you're in that moment and laying in that bed or you're in that room, it's like, hey, is this going to be helpful to you right now because of XYZ?
And I think that's a really good point because, and I stress this to my client, like if somebody says they want a completely unmedicated birth and that is very important to them, I still talked with them about what their medical pain management options are, what epidurals are, because I think it's important to have that information because we can never plan what birth is going to
Right.
look like,
And when you're in the moment, you want to have that bit of
exactly.
knowledge.
And at least if we form a foundation of information before we go into labor, not everything is new. Like my biggest concern for my clients is I never want them to have to make a spontaneous decision. I want them to have the information so that they have time to process it. I don't know about you, but I know like my social media algorithm is somehow trained very much. Like I see a lot more fear about epidurals and I see a lot more negativity about epidurals on my social media than I actually see the benefits. And I feel like it's a very divisive conversation. And especially I think people have the expectation that because I'm a doula, I only do unmedicated home water births, which is not the case at all. So, I mean, there are benefits to epidurals. We know that they're highly effective at pain relief. We know that many people are able to actually sleep with the epidural. So like if you have been having a long labor or not even a long quote unquote
whatever
long
you want to break,
whatever you want to break. Like I had a client in November who she wanted to have the experience of laboring. She didn't want the epidural right away, but she knew that she probably wanted the epidural after having felt what labor feels like. And so she was laboring in on the 3rd floor of the IWK. She got her epidural. She fell asleep, because often people do after the epidural is placed. And she woke up and she said, that was the best nap of my life. Like her baby is 4 months old. She's still talking about her epidural because it was such a good nap.
Amazing.
So like that can be an amazing tool for people to have, because we don't want to discount the fact that labor is a marathon. Sleep is a big part of our energy. Having that break, having that mental reset of being able to fall asleep and just step out of the moment at the time. There is also the benefit of like, again, we're not seeing overall increases in C-section rates, but it does give us a level of ease if there was a reason to go to C-section, because that epidural is already placed. The doctors are able to increase the amount of medication going through the epidural and use that as the anesthesia for a C-section instead of having to do another procedure to put the person under. And like, I think the number one myth I see about epidurals in kind of the social media space is that they will inherently lead to chronic back pain afterwards. There is a very, very, very low chance of a serious complication with an epidural. It's like 0.00000001. And they're actually like, epidurals are considered to be less risky than using an injectable opioid like morphine or like injectable fentanyl, which is also offered in the hospital. So there are unfortunately some people who do have back pain after laboring. Oftentimes, having talked to chiropractors and physios, oftentimes that back pain is actually not due to the epidural. It's due to something else that happened in labor. It's due to carrying your baby for 9 months. Yeah. There's other factors involved, but it gets people associate it with their epidural, because of course that was a puncture.
Oh, sure. And you do sign a consent form prior to. Absolutely. So we know that there are
some risk, but like anything, like any commercial for medication, more than half of the commercial is all the possible side effects that you could get from that.
I mean, we do things like documented risks of epidurals beyond this like very small risk are it might take you longer to push out baby if you can't feel your muscles contracting to push them out. That can take longer depending on your response to the medication. You might have difficulty moving your legs or walking. We do know there's a higher risk of use of vacuum and forceps to deliver baby, higher rates of C-section stress. We do see some abnormal heart rate tones with baby. Some babies will be born with lower APGAR scores. So that's not to say they are completely without risks, but everything we're doing within the medical space has risks, and birthing without an epidural has risks.
Sure.
It's that balance of what those risks and benefits are for an individual person in their particular situation.
And what do you feel like is going to help you through this moment that you're in?
Yeah.
I find the best way that I can, because I think, take it back to prenatal class, before we talk about the epidural, we do practice comfort measures and different ways that partners can apply pressure to help comfort the person who is in labor to feel better. And so whether that kind of takes them through their whole labor or until they get the epidural or what have you. But the idea is with those and different positions is not just to stay comfortable, but also to help labor progress and be mobile. So I think people worry, naturally so, if I get the epidural and I'm not mobile, what's that going to do? But the thing is we'll all have different levels of mobility, as we just talked about, but you can absolutely, even if you have the least amount of mobility, your legs are heavy, we can't get much movement, you can still usually get up on the squatting bar. You can still, with support, help people to shift from side to side or hands and knees and things like that. So still encouraging some movement, even if it's just putting that peanut ball between your legs, and then every 20 minutes your partner like switches legs, which one's on top, because that's still going to help labor progress if you're laying down and if you are in bed.
And I think if you are thinking that an epidural is a possibility in your birth plan, and I mean, if you have a doula with you, they're going to help you take all those different positions based on your level of mobility. The labor and delivery nurses at the IWK are all trained in that positioning as well, and are often very good about helping you do that. But it can be great to make sure that you know those comfort measures or different types of positions related to mobility. What's helpful kind of earlier in labor versus what's helpful later in labor. So that if you don't have the support people with you, you don't feel like you don't have options.
Yeah, totally.
I just want to say, like, based on kind of the atmosphere I see on social media where epidurals can be so divisive, that it's not that there's a one size fits all, this is the best option. Like, no matter what you are, whether you have an unmedicated birth or you have an epidural or you have some other type of pain management, you're still birthing your baby. You're still providing your baby with good outcomes. You're still providing yourself with good outcomes. And so it really, I just want to kind of like interject some space that is not that value laden. One A or B is a better option.
Yeah. I appreciate that. That's definitely the approach I like to give. Is like, yes, there are facts, is some research around this, and we can share that, but we have to take that all into context with the moment that we're in and what our values are, yada yada yada.
Exactly.
I would say, to wrap things up, for me, that because I am open and sharing my experiences, and I do that in class a little bit to help with the education side. I'm not just saying, hey, here are my birth stories, but like, people I think can genuinely be curious of like, okay, given all this, and you said you had some epidurals but you had a labor with one,
what did you think if you were to have another labor? Like, what would you do?
Exactly.
And I somebody asked me that actually not too recently, and I first was like, by God, I hope I don't have another labor. And not because I didn't enjoy it, but we're good with 3 kids. But I said no, I would probably say no to the epidural, but not because I don't think it's valuable. I literally remember after having our 3rd child, and I was feeling pretty damn good because I was like, I did it. I did it without the epidural. Not that I think before I just had a different mindset. I had more knowledge. My partner had more knowledge. Yeah. And it was a completely different prep for that labor. But I remember thinking specifically in the labor and delivery room after that, would I go back to the Ashley that had her first child and wish that she didn't have the epidural, knowing that, look, I can do it. I did do it.
Yeah.
And I immediately was like, hell no. That Ashley, 12 years ago now, she needed it. She wanted it. She got it. And it was awesome. It was very helpful because in that scenario, I needed it.
Yeah.
And so again, it was just a different planning, a different strategy, having had experience. Like, there's so many factors that went into that decision to not have an epidural with my 3rd child. Mm-hmm. But then you go in the room and now you're doing stuff. You're doing things differently than you would if you're just going to wait for medication. So to each their own. It is there if you need it. There's other possibilities if you don't get it or want it. But I think this is really helpful to help people understand the facts, and we're breaking down sort of the very common questions that we're hearing. So thanks.
If you're looking for more information or support along your parenting journey, check out birthbabysleep.ca. That's where you're going to find prenatal classes, postpartum and new baby resources, and sleep support during the childhood years. Lastly, but certainly not least, if you got something out of this episode or our show in general, leaving a rating or a quick review goes a really long way to helping others find us. So please consider leaving one. That's all for now. I'm Ashley Cooley, and we'll see you back here next time.